Hello, my name is Lieutenant Douglas Johnson, and I'm going to be discussing anesthesia management for cesarean section today. According to the most recent data by the CDC, in 2012 the rate of cesarean delivery in the United States was 32.8%, so approximately one-third of all births were through surgical means. The indications for cesarean section are previous cesarean section, increased risk of hemorrhage, abnormal fetal position, fetal distress, multiple gestations, umbilical cord prolapse, or a maternal disease process that can be transferred to the baby. Although it is possible to attempt a trial of labor after cesarean delivery or successfully have a vaginal birth after cesarean, it was typical for OB physicians to offer a subsequent cesarean section to these patients. Placenta previa, depending on the location, may make a vaginal delivery impossible. In these patients, a cesarean section is usually performed after 37 weeks of gestation. In patients that are actively bleeding and are hemodynamically unstable, an immediate cesarean section is indicated. Placenta accreta is an abnormal adherence of the placenta. It's further broken down into accreta vera, increta, and percreta based on how invasive it is into the uterus and surrounding pelvis tissue. Cesarean section with or without an associated hysterectomy is the standard treatment. You should be prepared for massive blood loss and the administration of blood products with any of these scenarios. Abruptio placentae is a premature separation of the placenta from the uterine wall, and severe abruption is a life-threatening emergency and requires an emergency or a crash C-section, as some would call it, and you should be prepared to give blood products to these patients. In a breech presentation of the fetus, the shoulders and head can become trapped after delivery of the body, and it is reasonable to perform a cesarean section on these patients. Fetal distress with multiple late decelerations, the loss of heart rate variability, or sustained heart rate of less than 80 are causes for an obstetrician to call for a cesarean section. Multiple gestations can be the cause of a cesarean delivery, whether it is the initial plan or if it is required to deliver the second and subsequent fetuses. Umbilical cord prolapse can cause cord compression and fetal demise. Steep Trendelenburg or kneaded chest positions with manual pushing of the cord back into the uterus is used until induction of general anesthesia completed and emergency C-section is performed. The presence of maternal disease states such as active herpes lesions may also determine if cesarean section is needed. General considerations for anesthetic management for cesarean sections include: all patients are considered to have a full stomach, minimal fasting times apply in the absence of an emergency. All patients should be pre-medicated with GI prophylaxis. The operating room table should be ramped to maximize airway access if needed. All protrusions should have a wedge under their right hip to produce left uterine displacement while supine, and the patient should be on oxygen until the fetus is delivered. Minimum fasting times include 8 hours for heavy meals, 6 hours for light meals, and 2 hours for clear liquids. GI prophylaxis consists of 15 to 30 milliliters of a non-particulate antacid such as sodium citrate, an H2 blocking medication, and or metoclopramide. The addition of metoclopramide is used to accelerate gastric emptying, decrease gastric volume, and increase lower esophageal sphincter tone. Let's talk about getting prepared. A pre-anesthetic evaluation should be performed on all OB patients soon after admission. It should consist of a focused health history of current and previous medical problems associated with this pregnancy, obstetric history, drug allergies, and baseline vital signs. A physical exam consisting of a thorough airway assessment, auscultation of heart and lung sounds, and an examination of the patient's back for possible neuraxial anesthesia should also be performed. Patient consent should be obtained early to clarify any questions the patient may have and to be prepared for an emergency situation. A determination should be made whether to type and screen or actually cross-match blood products for the patient. A history of a previous cesarean section or the presence of a placental abnormality can help determine this, along with departmental policy. All ASA standard monitors and fetal heart rate monitoring should be available in the operating room and should be checked at the beginning of your shift. Equipment for rapid infusion of blood products and adjuncts for a difficult airway should also be readily available. Airway will be discussed in more detail later in this presentation. All medications for general and neuraxial anesthesia should be available in the operating room. Also, specific medications to treat local anesthetic toxicity should also be available. Ensure you have vasopressor medications readily available to treat hypotension after neuraxial anesthesia or after induction of general anesthesia as well. NPO guidelines previously mentioned should be observed in patients undergoing elective cesarean section, but aspiration prophylaxis should be administered to all parturited patients. Prophylactic administration of a narrow-spectrum antibiotic is recommended within 1 hour of the start of the cesarean section. The most common is 1 gram of Ancef. Ensure that you have adequate IV access for the clinical situation you are presented with. Have at least 1 large bore IV and 2 if you expect to give blood products. Every cesarean section patient needs to have a wedge or a bump under the right hip to produce left uterine displacement and minimize aortocaval compression. The 4 methods of anesthesia available for a cesarean section are spinal, epidural, combined spinal and epidural, or general anesthesia. If a spinal or epidural method is used, a T4 level must be achieved for adequate anesthesia. The specifics about neuraxial anesthesia are discussed in another presentation, so I will only discuss the particular aspects that relate to a cesarean section. When using a neuraxial technique such as a spinal or epidural, it is recommended that the patient receive a fluid bolus of either 1,000 to 1,500 milliliters of crystalloid or 250 to 500 milliliters of colloid to help prevent hypotension related to the sympathectomy produced by the local anesthetic. Spinal anesthesia can be performed with the patient in either the sitting or lateral decubitus position. 10 to 15 milligrams of bupivacaine or 50 to 60 milligrams of lidocaine is injected into the subarachnoid space. Lidocaine will provide approximately 45 minutes of anesthesia, so if the procedure is expected to last longer, then bupivacaine is preferred. Bupivacaine should produce adequate anesthesia for approximately 1.5 to 2 hours. Along with the local anesthetic, 10 to 25 micrograms of fentanyl and 0.1 to 0.3 milligrams of preservative-free morphine can be added to the injection to produce a denser and longer block. Additionally, the morphine can produce postoperative pain relief for up to 24 hours. But please advise your patients that this may cause itching. Typically, the use of an epidural as your primary anesthetic for cesarean section is due to the fact that it is already in place because the woman was using it for labor analgesia. The dosing for a continuous labor epidural is not sufficient to perform a cesarean section, and it must be redosed. 15 to 25 milliliters of either 2% lidocaine with 1 to 200,000 of epinephrine and bicarbonate, or 3% chloroprocaine is titrated in 5 milliliter increments to produce a T4 level block. The addition of 50 to 100 micrograms of fentanyl or 10 to 20 micrograms of sufentanil can be added to increase the density and duration of the block. In the event that you have a patchy epidural, 10 to 20 milligrams of ketamine can be given intravenously at the beginning of the case to augment analgesia. If this is not sufficient and the patient continues to have pain that is not tolerable, then a general anesthetic may be needed. 2 to 5 milligrams of preservative-free morphine can be injected through the epidural catheter at the end of the case to provide 6 to 24 hours of postoperative pain relief. Typically, the epidural catheter is removed at the end of the cesarean section, but can be left in place for postoperative pain control if needed. A combined spinal and epidural gives you the rapid onset and density of a spinal block with the extended duration and use of an epidural catheter. It can be used when the case is expected to be prolonged or when the cesarean section is combined with other procedures such as a tubal ligation. And if you're at a hospital that has an obstetric training program, it may take a new surgeon a while to actually get the job done. Be cautious when using the epidural during the procedure. It is generally not tested with a standard test dose, so be sure to take time to properly aspirate before injecting, and titrate your drug slowly. It is possible for medications injected into the epidural space to migrate into the subarachnoid space after a dural puncture by a spinal needle. General anesthesia is used for cesarean section in emergency situations if there is not time to perform neuraxial anesthesia, if the neuraxial anesthesia does not produce an adequate block, or if you have a patient who cannot cooperate enough to have neuraxial anesthesia performed. This can include patients who are mentally impaired or impaired by drugs or alcohol. All patients are considered to be a full stomach and should receive aspiration prophylaxis and a rapid sequence induction. A thorough airway examination should be performed. The table should be properly ramped to maximize airway access, and you should be prepared for a difficult airway. Parturients have a decreased MAC requirement, and 0.75 MAC is normally enough to produce adequate anesthesia without causing uterine relaxation. Once the fetus is delivered, the addition of IV opioids is acceptable. An OG tube is used to empty gastric contents at the end of the case to minimize aspiration upon emergence. You can substitute 1 to 2 milligrams of ketamine for propofol as your induction agent in a patient who is hypotensive or hypovolemic. In pregnant women, we always worry about the airway. The reason is that there is a high incidence of failed intubations in parturients due to airway edema, large breasts that get in the way of the laryngoscope handle, and friable tissue in the airway that can swell and bleed with minimal manipulation. So you want to be prepared for the difficult airway. Ensure that you have several types of laryngoscope blades, short laryngoscope handles, 3 endotracheal tubes available, sizes 6, 6.5, and 7, a glide scope available, an intubating LMA, and the ability to provide transtracheal jet ventilation if needed. The last item I'm going to address is uterine tone. This is something that you should be aware of throughout the procedure. Hemorrhage is addressed in a separate lecture, but it is the most common complication associated with obstetric anesthesia. Before the case starts, you should have 1 liter of fluid with 20 units of oxytocin mixed in it, spiked and ready to administer as a bolus once the baby and placenta are delivered. You should also have 20 more units ready to add to the bag if it is requested by the surgeon to double the dose. If required, a 2nd liter of fluid with 20 units of oxytocin should also be available. Methogen and hemabate should also be readily available for administration in the event of uterine atony and bleeding. These are my references. Thank you very much.